Hello and welcome to another episode of Transforming WHO, a series of video interviews where I talk to colleagues inside WHO about the work we do and how we transform. And we've set up a temporary studio here at the corridors of the World Health Assembly, which is currently taking place in Geneva. And in this temporary studio, I'm very happy to have Rik Peeperkorn, who is the WHO representative to the occupied Palestinian territories. And welcome, Rik, and thank you for taking the time in your very busy schedule to join me here in the studio. First, a little bit about yourself and your career. You have almost 40 years in global health and public health. Originally a medical doctor graduated from Amsterdam, worked for some years in your home country of Netherlands, but then you spent quite some time, I believe more than 15 years, fighting HIV and AIDS in several African countries, also working for UNAIDS, also building health systems in Tanzania, South Africa, other countries in Africa. And then eventually you joined WHO, I believe 12 years ago. First 8 years as head of our country office in Afghanistan, as what we call WHO representative, which is the head of the country office. And then the last 4 years in occupied Palestine, where I believe the country office in East Jerusalem, but of course you serve Gaza and the West Bank in that capacity. Is that a fair summary of your impressive career, Rik?
Thank you very much. Yes, I can a fair summary. Spent most of my time indeed in Southern Eastern Africa, actually working for local governments. I worked for the Zambian government as what they then called the Senior Medical Officer of the Northern Province. I worked before that actually as a JPO for UNICEF in Pakistan and Afghanistan. That was on the late 80s. I did also a stint for UNICEF in Madagascar. But then it was mainly Southern Africa. So Zambia, Malawi, Zambia for the Zambian government. And then I became a diplomat because in the Netherlands we don't have a specific Netherlands, Netherlands Development Agency. You're part of Ministry of Foreign Affairs. And you work as a sector specialist, health, and then I covered Zambia and Malawi and Southern Africa. Correct.
So almost 40 years in global health. That's impressive, Rik. A fair part of that was, like I mentioned, HIV/AIDS. So I thought we'd maybe start there because, I mean, HIV/AIDS is actually a success story. When we look at the last 25 years, we made antivirals more accessible. Many programs have actually brought down the incidence of people who got HIV and mortality. We're not there yet, but certainly many successes. But now we are facing a crisis because of the withdrawal of the US and funding, especially the PEPFAR program, which was funded by the US government. So how does that strike you? I mean, having worked with that area and now seeing the current crisis.
Yeah, I have really witnessed very much personally the horrific impact of HIV/AIDS. When I started in Zambia, and that process, when I started in Southern Africa, that was in Zambia 93, 94, up till 2002. And then you saw almost this HIV/AIDS wave coming from Central Eastern Africa, actually rolling over Southern Africa. And I was there in the Northern Province, and there were no antiretrovirals. There was too little known, at least among the communities, about HIV/AIDS. And we were struggling always, and on many, many ways. And the only thing we could follow, I was working then for the Zambian government, was prevention. And he had this famous abstention, the prevention, use of condoms, etc., and care. But in the meantime, so many people were dying unnecessarily along the way. And I was then a young physician and a public health expert, etc. I will never forget that. So everywhere around, you were your friends and young men, women like yourself, etc. And at one stage, so you could almost see you were sitting in the meetings, etc. And then you thought, oh my God, she's also HIV positive, or he's also. You saw sometimes skin discoloration, etc. So we went through this horrific phase, etc. Then finally, when ARVs became accessible, and I think I really want to credit the civil society, and specifically the civil society in Southern Africa for that.
And for the advocacy and making the constant argument of making the antivirals
Exactly.
accessible.
And of course, and then together with WHO and UNH and many other of the agencies pushing for that, and it changed it enormously. And now, I mean, like, and almost everywhere, the access to antiretrovirals has increased tremendously, and it is indeed.
But many of these programs are now being defunded.
Yeah.
I mean, they're losing funding because they are maybe overly dependent by support from the US government in many ways.
Completely. I think but I think first of all, so let's say, from an horrific reality, a relatively successful story in public health and in collaboration, not isolation. Collaboration, world collaborated and focused. That's how you can see what is possible. And this is, of course, really incredibly sad what is happening now when key partners withdraw from a fight against HIV.
And it's a balance between deep concern because of this, but also hope for HIV, because now we have lenacapavir, who is sort of a long-acting, injectable. It's almost like a vaccine. So we actually, on one hand, are discussing ending the pandemic of HIV. And then on the other hand, we are seeing a backlash.
Yeah.
Are you optimistic?
So we are almost, I think, on the, you would say almost, you would hope you're almost at the tail end of that kind of, combating that horrific epidemic. You said something about withdrawal of key partners like the US. I also think a lot of capacity have been built in all those countries. A lot of capacity is there, has been built. I think it's also a wake-up call from all countries around the world. Like, hey, is health important for us? Health should always be a top priority. Invest in health, invest in your systems, and of course, invest in HIV/AIDS prevention and control. And I think many of the countries do this already, and they can do more.
So that's also a wake-up call and opportunity for many governments in Africa.
Many of it.
Yeah.
And secondly, so that should happen, and it is happening already, but it should be really expanded. I mean, countries should really take that responsibility and much more themselves, which they are already doing, by the way. Then I also would hope and expect that other partners, wherever is necessary, and I think WHO could assist there, that we really analyze really well, we prioritize, we analyze better, where are the acute gaps, and focus on that.
Yeah. Moving a little bit further up in your career, so you joined WHO 12 years ago, 8 years as head of country office in Afghanistan, and now 4 years in occupied Palestine. So these are, I mean, a lot of humanitarian challenges in Afghanistan and certainly currently in Gaza. Some reflections on leadership, WHO role in these contexts. I mean, first Afghanistan and Gaza, in humanitarian crises and etc. I mean, what's the role of a WR, country office?
Well, I think that's a really good question. And I think I've been also evolving myself around those years. When I came to Afghanistan in 2013, and the first thing what I observed, that we had a strong and organized polio program, which was focused. What I realized, and that was a bit of a shock for me, that all the other programs were, that there was very little what we called assessed contribution, core funding, etc. And there was a little voluntary contribution, which was, again, completely volatile. I mean, when I came, I straight away heard, oh, you have to do something quickly because otherwise we lose a couple of national officers on communicable diseases, and we didn't even have one for non-communicable diseases, and we will lose international officers as well. So for me, the lesson is, and that's the lesson for WHOs, and I think probably it's on all levels, but specifically at country level. One, you focus initially and say, what is a core team? What is essential? Because you cannot do it alone as rep. You should be a bit modest and step back. What is a core team, and what can I delegate as much as possible? And a core team is absolutely not only international officers. Like in Afghanistan, there was probably a group of 15 to 20, and maybe 8 to 10 international officers and 10, 11 national officers. And you quickly sort that out. And then what are the most essential, what are the biggest needs? And of course, you coordinate it with governments and with other partners, and how do we focus better? Then you need to have a plan. You need to have a plan, and I think sometimes that is lacking within WHO, even a proper focus, and reach out to partners. So we straight away, we established the core team, I established the core team, and then we started focusing on, besides polio, learning some lessons from polio. How can we expand in health emergencies, because that was a huge need, but also in communicable, non-communicable disease and health systems, RMNCH, etc.
But what's the role of WHO in that context? Let's say Afghanistan, which is of course has many challenges. You're saying polio emergencies, etc., but also a difficult context, I could imagine, for security reasons, lack of stable government, etc. I mean, how does the WHO work? What's the role of WHO?
Well, so I'm very clear about that. I think, and we have seen a shift over the last, I would say, 10 to 15 years in WHO, where WHO in the past, when I was working in Southern Africa, was really seeing more norms and standards and guidelines and workshops and et cetera, et cetera. I think we realize we have to be much more operational when there is a need. When there's a need. Yeah. When there's no need, you don't be operational. So in very low income countries and countries in crisis, where there's a need to also assist and being operational in many areas, you should be ready for that. And not just in polio or health emergencies, also in other areas, in communicable, non-communicable diseases, and definitely in systems. Maybe I'll explain later a little bit better. Then of course you need your resources. Yeah. Well, we know that you cannot rely on sufficient core funding for that. So you need to have a plan, concept notes, etc. on each of those topics, and assertively, almost aggressively reach out to donors and partners. Not just for the short term, for the longer term. You have to build a reputation. You have to show that you deliver. I mean, we don't. You just don't get your respect. I mean, you have to deserve that. I mean, along the way. So we had a massive resource mobilization exercise in Afghanistan and ongoing. And that is not just the work of WR. That's the work of key technical officers, etc. And I try to work always with, we have a core team and I'm the team lead. Yeah. But then we have various teams. So I like to work, many people are team leads and team leaders. I do not believe, I think sometimes the UN was too fraught with, I would say, ineffective hierarchical structures, etc. We should be team leads, yeah, and coordinate as quickly as possible. Reach out and constantly inform your partners and also your donors. Work as closely with governments as possible. But also there, I want to make a division. You work as closely with government, the Ministry of Health. But we are not the secretariat of the government or a Ministry of Health. We are the independent global health organization.
We're there to support them, I guess.
And we support their priorities. Exactly. So we support them on the most evidence-informed way. And as we know, that changes sometimes over time, etc. And we constantly negotiate. The moment you're doing that and you sustain that, I've seen that both in Afghanistan, but also in Southern Africa and Eastern Africa, but definitely in Afghanistan and also in occupied Palestinian territory, you will get the recognition, but you also get the respect, and you actually improve your relation with governments, because they know first, trusted partner, a partner which also raises funds for health, not just for WHO, raises funds for the broader health sector, yeah, and a partner who delivers, and a partner who operates as independent as possible, evidence-informed.
And I guess much of that is, and the experience and the principles, the values you just mentioned, you took that into your current role as the WR for occupied Palestinian territory. And then you were thrust into a huge humanitarian crisis. I mean, what is happening, I'm speaking about what's happening in Gaza. Since October 2023, it's a devastating humanitarian catastrophe. I believe we just had the report here at the Health Assembly, the annual report on the health situations and I was just rereading this morning. This is devastating. What was reported by the DG. I believe now 53,000 people have died in Gaza due to the air bombings, etc. 120,000 people injured. Attacks on healthcare facilities and healthcare workers, which are, I mean, out of a scale we haven't seen. And most of the population of 2.3 million, most are displaced, many even several times. I mean, can you tell us a little bit, how do you see that personally? I mean, having worked almost 40 years in global health and then what you're faced with now?
I think that, having worked in Southern and Eastern Africa and going through this horrific HIV/AIDS epidemic, building up primary healthcare systems, etc., but changing. I mean, if you look at Southern and Eastern Africa now and you look at the infant and child mortality rates, they've massively decreased. I mean, and health has substantially improved all over the world. And yeah, we're all part of that. So I mean, we should be proud. We should not forget that. I mean, we're all part of that. And it is mainly the people themselves, their governments, and the local partners, by the way, who do that. Now, in Afghanistan, of course, I had so many lessons on emergencies and crisis, because it was a country in crisis all the 7.5 years, 8 years I was there. And yeah, I witnessed some horrific scenes all over Afghanistan. When I transferred to occupied Palestinian territory, I knew this was going to be complex, not just let's not forget that occupied Palestinian territory is in crisis for decades. It's not just recently.
Even before October 23, the healthcare system in Gaza was not very robust.
And there were they went through many what we now call escalations, which were wars, etc. I mean, many. Of course,
blockades of assistance, etc.
Yeah, but of course, what happened, and the explosion. So they say the explosion of this crisis since October 23. I think none of us have ever witnessed, and I think it's very difficult to even be prepared for something like that, and I'm afraid it will have an impact for decades and decades to come, and long after I'm gone, it will still have an impact. It's changed the not only the Palestinian-Israeli conflict, the regional, the global context, etc. And yeah, that is, I mean, it's incredible. What did we do as, when this explosion or when this crisis, I would say, exploded? So first, we had already built up some systems and learned lessons from the former escalations. So I'm 4 years. So we had already a relatively strong health emergency program. And again, working with a core team, with smaller teams and team leads, and we had a strong foot on the ground in Gaza. We have an office in Jerusalem, an office in Gaza, and an office in the West Bank. A strong focus on health emergency and trauma care, which helped us. We always pre-positioned supplies, for example, essential supplies, etc. The mass casualty management training had been done. And what was really helped to save lives and reduce morbidity with the former escalations and crisis in Gaza. But this time, I mean, all our supplies, they were used within days of this crisis. So what did we do? So when we saw this happening from early October, straight away, the same almost day, I changed the office completely. We came together. We focused almost everyone on humanitarian support, still trying to continue the development activities we did. Then, of course, the focus was very much on Gaza, and the first focus was on our team, because from the 26 national staff, more than 20 were based in Gaza city, etc. They were fleeing like all Gaza. I mean, Gaza
so focusing on the security and safety of
the
staff
also, which is very complex, because they were in shelters and this and that and whatever. Fortunately, we had 4 to 5 staff still. They were operations. They were their houses were in Khan Yunis or in Rafah, and we were lucky. 2 tactical officers, a driver, and some operation officer. I remember we only had a very small core team in Jerusalem because some of our international staff were out. The team lead health emergency didn't even arrive yet. But with that core team, what we did straight away, we repositioned. So we used first the existing funding in the most flexible way, and we repositioned that. Our warehouse was destroyed in Gaza City, our office. So in the same week, we hired 2 warehouses in Khan Yunis. And I want to credit also the whole organization, 3 levels here. I had immediate contact, of course, with my regional director and team, but specifically also with here at HQ, not only with DG, but very much Mike Ryan and his team. And we straight away got funding from the CFE. So the CFE, the contingency fund for emergencies, it works, and it should be really. And I raised it with all member states.
Of course, also getting a focus on getting supplies in from our warehouses in Dubai and supporting with emergency.
So we were, and because of that, so we quickly had 8-9 million, and we were already working. And we were the first one to get supplies in through Egypt, from Dubai, and through the Dubai up and everything, to those warehouses. And we were the first one, not what you normally expect for international NGOs. So WHO being super operational from the start, we were the first, the second, the third, and fifth one who actually got those supplies to the north, to Shifa and the other places.
The WHO provides is, of course, emergency supplies, it's healthcare supplies, medicines for surgery, etc. But what I think many people don't know is that WHO is actually also supplying fuel for the generators in many of the healthcare facilities and hospitals. I mean, so it's a broad sort of emergency supply service we run.
Yeah, but for me, the main lesson learned, because you asked what the main lesson learned, first, make sure you have a core team that you can straight away focus, have the right contacts at HQ in the region, etc. And then we straight away, we set no regrets policy, so we became operational from the start. We had a plan, and I really credit the WHO OPT core team for that. With assistance we had a plan within weeks, an operational response plan, which we straight away vented out to all key partners and donors, etc. So we did incredibly well on resource mobilization. Up till 24, over 250 million. I mean, yes, with assistance from HQ and the region, but the bulk was coming from the work was at OPT. So that helped us, of course, to set up. What did we focus on? We focused first on 3 humanitarian pillars. That was first, how do we maintain essential health services? And that everything, primary health care, referral care, etc., underpinned by this constant stream of essential medicines, medical supplies, the whole operation supplies and logistics area. Then, when emergency medical teams got in, we facilitated the emergency medical teams in. There are 35 emergency medical teams. WHO supports them not only with supplies, but also to bring them to their stations and the hospitals, etc. 3, medevac. WHO has been facilitating and supporting over 7,000 patients to be medevaced out of Gaza. That's an enormous operations, internally medevac and then externally out of Gaza. Egypt and many other countries in the region and all over. So that was the third component. Then, in the meantime, we also carried out 2 polio rounds and 2 polio campaigns together with the ministry and UNICEF and UNRWA. And you can see what is feasible. That was one campaign during an active war and the other campaign during a ceasefire, etc. With coverages over 90, from 90 to last one over 100%.
It must be a constant challenge, because I read the operational plans, and I think that, as you say, is excellent, because it basically shows what we want to do and what we can do, and then it becomes an investment case also, and then the dashboards, which are basically showing the challenges but also what we do. But it must be very, very difficult navigating for you and your team in this constantly changing atmosphere. Then there's ceasefires, then hostilities break out again, and healthcare facilities are constantly being attacked and being non-functional. I mean, and now it's going 20 months. I mean, how can you keep up that support?
Well, I think you're right. the planning and the resource mobilization are incredibly intense exercises, but that's one thing. And again, the focus is on essential health services, on public health intelligence, also on coordination. WHO leads and coordinates, and then we start working on early recovery and rehabilitation. The most complex part has, of course, been the people first, the Gazans themselves, but also our staff on the ground. So a huge number of the WHO staff self-evacuated themselves. Almost everyone in Gaza, including our staff, they either lost family members. We lost Dima, a fantastic young professional in working for WHO, and her whole family when their house was bombarded, and 31 of their family were killed. All WHO staff, they either lost family members, they lost friends, neighbors, they lost houses, they lost a lot of their memories. A number of them self-evacuated. We had to constantly recruit new staff, get international staff in. So I give a lot of credit to the team within Gaza, the team within Gaza, both the international, the team leads, and the national staff. And then the Jerusalem team, from the Jerusalem team, we were constantly rotating into Gaza and assisting where needed and where feasible as well. With the support from some search staff, I want to also say 3 levels again. Initially, we got some really excellent search staff from WebPro, for example. We got 3 people from Fiji. I'm still grateful from them initially, from HQ and from the region. So the most important part was building up that team, but also trying to care for that team. And that has been difficult because all the staff, very quickly, we try to get the staff out of the shelters and try to get guest houses for national staff and international staff. And just to remind everyone how horrific this war has been, I mean, for everyone. The story of staff, I mean, fleeing from the north, shelters, guest houses in Rafah, the same. We had warehouses in Khan Yunis. In February, I got 6 hours. I got a call from the Israeli army. You have 6 hours to get your supplies out of that warehouse, etc. We were just in time. Those warehouses were destroyed. Then we had warehouses and guest houses in Rafah. After the siege in Rafah, our warehouses were destroyed there, and our guest houses we couldn't save. So we had to move to Deir Bala. All of that constantly. So to keep, and maybe what is because this is a secret. First of all, it's resilience. Resilience of the Palestinians overall, but I don't like that word because you know, nobody needs to be so resilient. I mean, like over time, but it has been the resilience of Palestinians and the WHO staff. What did we try to do? Again, constantly work with a core team, with smaller teams. Constantly reprioritize, adapt your plan where it's needed. Be flexible. Have a very short lines within the team and overall. Also, don't take yourself so serious. That sounds a little weird, but don't take yourself too serious. And try to keep a sense of humor. And I think on all levels, I think we managed that to a really extensive level. Did we do everything on the right way for ourselves and the staff? No. And I try now, I think initially, definitely this core team, we worked like crazy, and we worked all weekends for the first 6 to 9 months, etc. And now we try to say, please take one day in the weekend, try to reflect and relax.
As we sit now here speaking, I mean, the situation in Gaza, as I understand, is that after a ceasefire, hostilities broke out again in March. There is now a very grave concern about the blockade of humanitarian assistance going into Gaza. So there's been warnings of an impending famine, and certainly still many healthcare facilities non-functional or only partly functional. So it doesn't appear very good now 20 months into this conflict. So what's the next step? How do you see the next operational plan?
Well, I think you're completely right. So last week was my last mission in Gaza. I try to be there every second month for a week or 2 weeks, or with polio even 4 weeks. Last week I was there, and every time you come in Gaza, and that is really also really horrible. So during the ceasefire, there was some kind of hope. And I was there also during the ceasefire. And the south of Gaza and Rafah and the north and Jabalia, it's a wasteland. Parts of Khan Yunis is wasteland. Part of Gaza City, wasteland. But there was some sense of hope. You saw families, even some of our staff returned to their houses in the north. They were setting up tents next to their destroyed houses, etc. And there was a kind of a spirit of hope. That, of course, that hope is again vanished at the moment. And every time you think like, okay, the situation cannot get worse, it gets worse. So the current situation, not only the aid blockade, the resumption of the war and hostilities, etc. I was always very optimistic, and I'm pretty optimistic, and I still want to be optimistic. I want to remain optimistic because it's the only thing which we have. But every one of you're all reading the media, etc. So yeah, we have to prepare for every scenario. So the worst case scenario is, of course, that this war continues and this ground offensive continues. And that's what we've seen over the last couple of weeks. Again, 600,000 people were forcibly evacuated, for the X time in this period. We saw we lost hospitals and health facilities just over the last 6 days. We lost 4 hospitals; they became non-functional, etc. So the worst case scenario, of course, is that this war continues, that many more people will be forcibly evacuated to the south of Gaza. I mean, like that was that original plan, indeed, like around Mawasi and Deir Bala, etc. And then what happens then? Yeah, that's and will they be forcibly be evacuated outside Gaza? I don't know, but that's of course the worst case scenario. The other case scenario, which is in between, which is also a bad case scenario, is that we continue where we are now. I call it muddling through. We have an active war now. Maybe then we have a temporary ceasefire, etc., and then again hostilities, etc. That is the mean. And then the best case scenario would, of course, be, and that should be the only scenario, that we go to a ceasefire and that we can
and of
start.
course, we need to say also, this is exactly what the WHO has been saying and keeps repeating, and we heard our Director General saying it yesterday. We are calling for an immediate ceasefire, of course, allowing humanitarian aid, releasing the hostages. We also need to remember that, and then of course helping Gaza to rebuild their healthcare system. This is what the WHO is calling for, but you're saying it's difficult to plan for that because we don't know.
I think WHO, we've been very consistent, of course, releasing the hostages, a ceasefire, make sure that the UN and the humanitarians can do their work, get the goods in, and make sure not only into Gaza, but all over Gaza to where it's most needed, and then start
course
building.
Also protecting health facilities and protecting healthcare professionals. This is ingrained in our DNA, even from our constitution in WHO, that we are here to protect health facilities.
Absolutely, and that's why we have this mandate, and we monitor, we analyze reports on attacks on healthcare, and we constantly report on that as well. But you asked me like that, so are we prepared for these phases? First and foremost, and that's my message to all the member states, whatever happens, Gaza will need humanitarian support for years to come. Yeah, in the best case,
no matter what happens.
No matter what happens.
Also with ceasefire and peace
even with
to rebuild.
ceasefire and early recovery, they will need humanitarian support for a year to recover. In the best case scenario, when the ceasefire and we can start early recovery, rehabilitation, it will be a combination of humanitarian support and development support. WHO we are ready for all. Well, not ready. We have a plan for all phases. So what is now my concern? And you started with HCVH and the turmoil the multilateral system is and the reduced funding. So we did relatively well in resource mobilization in the first 18 months. And from the over 250 million we raised up to 24, we spent and allocated more than 90%. We delivered, we reported, and we delivered. Yeah, it gives us a lot of credibility. Now, number of donors. And we did a new resource mobilization round based on our WHO Operational Response Plan 2025. A number of donors They came to us and they say, yeah, we're going to continue, etc. But it's too few. Many partners we can see now, and we hear this all over, they keep their cards against their chest and they wait.
Yeah.
And even having been a diplomat and worked for that, I can see that point. You want to invest in something where you say, hey, it should be worthwhile. But this is no time to wait for humanitarian support. So that needs to be supported. So we do another round. We are, and here on the Health Assembly, I also approach a lot of the delegations and the same message. So that definitely should happen. The second point, member states should stand firm. The UN and humanitarian partners, they have a proven support system, humanitarian support system, which has worked. Yeah. And definitely also during the ceasefire, which worked very well. There's a plan in place. There is no need for another system, and even more when it is not based on humanitarian principles.
I mean, certainly we are in a huge crisis. I mean, with the lack of funding that because of the withdrawal of the US government, and many are sort of being concerned about the future of global health. How do you see that?
Well, first of all, I think in general, people all over the world, the majority believes in collaboration and coordination. The world has become very small, as we know, and they believe in collaboration and coordination, not in isolation. So I know that we hear and we see a lot of movements which is more focused to isolation instead of collaboration. I hope we have seen these waves before, etc. I hope it will come back, and I expect it will come back. When I look at international health, and I think if you ask anyone around, is there need for a global health organization, a World Health Organization as we have? Everybody will confirm there's a need for a World Health Organization. Now, there's been a lot of discussions, and I think in the introduction, you already asked me, how I saw that, and should there be changes, etc. And so currently, even in a time where funding becomes more scarce, funding should not be scarce. I mean, that is one thing. Funding should not be scarce for global health, but I'm realist enough that this is happening. I think the first thing we should get across to all member states and people that you want a multilateral system with key organizations like WHO who work as independent as possible. And what I mean with that, I'm not naive. Health is politics and politics is health. So there will always be political influences, etc. But what you, of course, really want, you want a WHO which works, and I think we've proven that we can do that, which works as evidence-informed as possible. We work hand in hand with governments, with NGOs, with private sector, civil society, etc., academia. But we need to radiate. We are the independent global health organization, and this, if this is the agenda we push, I think finally we on the long term you will get that respect, because finally countries will realize that if they are pushing a policy or an approach which is maybe not in line what the WHO, or let's say based on evidence informed, is the more effective approach, we should stick to that, and we should always realize, finally, all of us, we work for the people, and in this case, what I'm doing, we work for the Palestinian people. I mean, and we work with all these partners, including government, to that. And when I then look at WHO, I mean, because there's so many talks about the transformation, etc. Where should we go, and how should we focus, etc. Yeah, of course, I also have ideas about that. I mean, and when I start, let me start at country level. And I like it that I constantly hear, hear that here, that country level and our work at country level should be prioritized and supported. However, I think we should constantly focus and reprioritize and really focus what is needed, what is really needed, and do we have the tools and the capacity and the people to address that. Also, when the resources are scarce, on which group of countries do you focus? For me, it's very clear. You focus on the countries in crisis. You focus on whatever level it is, low income, middle income, high. Country in crisis needs support. You focus on very low income countries and low income countries. I don't say that middle income countries and high income countries and very high should be neglected. Oh no, in contrary. But if they need support, direct of WHO support, they should contribute to that, and they should actually assist WHO then to be able to implement.
But by the end of the day, as you're saying, there will still be a role for WHO also through this crisis if we prioritize and basically focus on serving the people in need.
I think absolutely. Now, absolutely. So for me, multilateralism is absolutely not that. Does it need a reform? And maybe I'm a little direct, I'm blunt, but when I see that sometimes we have over 30 UN agencies and I believe thousands of mandates, I think there is a need for refocus. I can see that some agencies can merge and focus, etc. Also within global health, there's absolutely need for a strong World Health Organization. And going back, I made my plea for country and the country focus and on which group of countries, etc. I believe also in a strong HQ, a strong center with a focus on norms and standard, with a strong health emergency program and health emergency program like that, which helps countries in crisis, etc. With a focus on areas which countries now need. And let me say something because so much countries have so much capacities themselves. And in areas, for example, on communicable diseases, on HIV/AIDS, TB, malaria, etc., but also on mother and child health, a lot of capacity has been built. Where often they need support is in areas besides health emergencies, it's in areas of health financing, whole health information systems, health systems area, but also, of course, non-communicable diseases and mental health. So focus on that. The regions for me should also have a key role and fork almost like a technical support facilities. And for example, in the Embro region with the Dubai hub, that we have this very strong link to operations, supplies and logistics. But we constantly have to analyze what is really needed at country level. Are we focusing? Are we prioritizing, etc.? And will it have an effect on health, improving health, on the people within countries, within territories, on the ground?
Thank you very much, Rik, and thank you very much for sharing your experiences and also your points of view. And I wish you good luck in the important work that you're doing with your team in occupied Palestinian territories. And thank you very much, all of you, for watching this episode of Transforming WHO. And do stay tuned on this channel for upcoming episodes.